Osborne waves have a unique connection to body temperature. How are they discovered, and what are their other names? Sounds like they've had quite a few aliases.
They certainly have. These distinct waves were first reported by Tomaszewski in 1938 in a patient suffering from hypothermia. However, it was John J. Osborne in 1953 who extensively described and firmly attributed this specific ECG pattern to hypothermia based on his research. They've accumulated many names: KJ or H waves, camel hump sign, late delta wave, hat hook junction. All describe the same characteristic ECG finding that emerges when body temperature drops significantly.
Are the underlying mechanisms for Osborne waves similar to other syndromes we've discussed, like Brugada or Heiseger? Seems like a recurring theme.
Yes, there are definite similarities, indicating a shared electrical vulnerability. Just like Brugada and Heiseger, both early repolarization and late depolarization are suspected. The repolarization hypothesis, more supported, suggests a transmural gradient between epicardium and endocardium is created. This can be triggered not only by hypothermia, but also by ischemia, hypercalcemia, diabetic ketoacidosis, hypothyroidism, sepsis, brain death, even drowning. Some less supported theories involve late depolarization, so while hypothermia is classic, the underlying disturbance mirrors other serious conditions.
Given its broad associations, what should clinicians look for when Osborne waves appear? It sounds like a clue to many different conditions.
Indeed, their presence necessitates a very careful patient history. As they aren't pathognomonic on their own, they're a signpost. They are, of course, common in therapeutic or accidental hypothermia. Beyond temperature, they can be seen in diabetic ketoacidosis, hypothyroidism, sepsis, brain death, Parkinson's disease, certain drug overdoses, drowning. Furthermore, they can appear in ACS, hypercalcemia, Takotsubo, myocarditis, concentric hypertrophy, or even as part of Brugada or Heiseger syndromes. Their presence always prompts further evaluation to find the true underlying cause.
Where do these waves actually appear on the ECG, and how do we differentiate between hypothermic and non-hypothermic causes?
The J point on the ECG is the landmark between the QRS end and ST start. When this J point elevates, creating a hump, that's the J wave or Osborne wave. To differentiate causes on the ECG, look for other clues. Hypothermic patients typically show bradycardia, longer PR, QT, QRS intervals, maybe shivering artifacts. Generally, the colder the patient, the steeper the Osborne waves. Distinguishing from Brugada and Heiseger involves evaluating their specific criteria, as the Osborne wave can be part of those patterns.
So, can the diagnostic criteria for Brugada or Heiseger syndromes be applied when you see Osborne waves? Are they sometimes overlapping?
Yes, exactly. In cases where the Osborne wave is part of the presentation of Brugada or Heiseger syndrome, their respective diagnostic criteria would be used to confirm the specific underlying syndrome, not just Osborne waves in isolation. The clinical context is key.
What's the prognostic value of Osborne waves? Does their presence indicate a better or worse outcome?
The prognostic value in hypothermic patients is actually quite debatable. Some research suggests higher mortality with them, others note worse prognosis in hypothermic patients without them. So it's unclear there. However, when Osborne waves are due to non-hypothermic causes, meaning they reflect a different underlying pathology, the prognosis is generally considered poorer. The severity depends on the ECG leads involved and the wave's magnitude. In these cases, they can be a serious warning sign,